next speaker, Dr. E. Varalakshmi. The topic is improving outcomes, science, arts and commerce. I am privileged to introduce Dr. Varalakshmi, who is a postgraduate in the Andhra Medical College. She did her DA in Andhra Medical College. Later, she finished at DCCM, and then finally she did DM critical care. Now she is, I am proud to say that she is one of the top critical care physicians in Visakhapatnam city. Now I request Dr. Varalakshmi to deliver the talk.
Thank you so much, sir. Thank you. Coming from a teacher means a lot. Thank you, sir. First of all, thanks for the opportunity. And this topic is going to be completely in contrast to sir's lecture. So I hope it really makes sense. I'm really tense now. So we've seen over yesterday and previous deliberations also that we are not getting concrete answers from trials, from randomized trials in critical care. So most of the times it is a could be, could not be kind of a situation. So that leaves us with very few concrete options for improving outcomes in terms of specific diseases or conditions in the ICU. So we look at improving quality in whatever we do, and the controllables are what we are trying to control. So to this end, we know that the quality improvement programs have been in place with standardization and improvement and innovation being the crux, being the core. So we look at with the sort of the focus being on patient safety or infection control. We have bundles that have been in place, then quality indicators that have been put in place for us to follow, audits, benchmarking, looking at compliance, accreditation, insurance payments are also increasingly being linked to these processes. Our societies are also having guidelines for the same. So with this background, we came across this editorial, this a set of articles that was published last year in current opinion in critical care. I'll just try to share a little bit of what I learned in this process. So the first one, it looks at digital solutions and the future of recovery after critical care. So we do succeed in taking patients out of the ICU, we send them to the ward, or a few patients we send them to home. But most of the times we are finding, especially in vulnerable populations, in elderly patients, in patients with multiple comorbidities, that they tend to come back. And the quality of their life post-ICU discharge is very, very dismal. So there are a series of studies that have been done in this realm. The first study is the impact study. So this actually looked at a nurse sort of navigator. They had a STAR, that's called a STAR program. This is a nurse navigator driven program. So basically what they do is, the basic crux of this program is they identify and treat new problems. They do medical reconciliation, they adjust their medication. They do surveillance of treatable chronic conditions, and they focus on care alignment, which includes palliative care. Now they looked at, in this study, they looked at a composite endpoint, which was 30-day all-cause mortality and readmission. So they did find a small sort of decrease in all-cause mortality in patients who availed this navigator program. But what is important for us is to look that the nurse, the navigator, had to engage 15 times during this period, which is 180 days, and spend a total of 170 minutes on each patient. So that is the kind of commitment and time that is required for us to make small changes in outcome. The second, people have used app-based technologies like this ICU digital recovery pathway. It has been shown that it is feasible, but outcome benefits have not been proven yet. Then virtual reality based programs, studies have been done. they are not showing any benefit whatsoever. Then there is this new ICU Together, it's a web-linked program. This is also looking at cost. It is doing a cost analysis. The study is in progress, so the outcomes are yet to be released. Next, coming to rehab. We know that the team trial last year that came up showed us that there's not really much improvement with early rehabilitation. Actually, it suggested that there was greater harm in starting rehab mobility, early mobility in the ICU much earlier. So with this, there are a very few very small observational studies which have been able to show improvement with early mobilization in the ICU. But beyond that, there is not much evidence. That is because basically there is too much of heterogeneity as to what group of population have been studied, what is the amount of sort of mobility that they are aiming to, what is the dose or the duration of mobility in the ICU is very, very different. So they have not been able to really give us any sort of meaningful information as to when we should start mobilizing patients in the ICU, to what extent we should mobilize. Because these studies are they have a very tunneled view, they look at a very small aspect of it. So we don't have too much information there. Next, coming to sepsis in cancer and acute respiratory failure in cancer patients. Increasingly, we are seeing that a lot of the prevalence and incidence of cancer is on the rise. Along with that, because of the newer therapies that are becoming available, a lot of these patients are coming to the ICU. So given this situation, the problem again it's the same. There are three major problems. One is there is too much of heterogeneity in this population. So I'm sure none of the regular RCTs will not give us any information as to which what will be useful in these patients and what will not be useful. So subphenotyping is the only way to go. Like we have in sepsis, the fever trajectory or the phenotypes based on the fever or based on the inflammatory markers, initial vasopressor requirement, something like that has to come. Until then, it will be very difficult for us to give information on this particular patients. The second thing is time is of essence here. So early warning systems and rapid response teams, which are specific to cancer patients, are being studied, and what we actually need is a predictive model which will give us, but then these predictive models again are very complex as of now. So right now we don't have too much information on this realm as well. The third thing is what do you measure? When you look at a patient with cancer in the ICU or this cohort of patients, what is it that you want to measure and say this is going to be good for this patient? Is it only mortality? Is it the length of stay in the ICU? Is it the quality of life? Quality of life at what point? And because there is ongoing chemotherapy going on, these therapies, the targets are constantly moving. Now suppose this patient gets included in another trial or uses another medication. So our approach on this patient will be completely different. So that is the reason there is a lot of confusion, because even till today, whenever there is a patient with a a advanced malignancy, it becomes very difficult for us to give a clear understanding to the family as to this is the possibility of your patient recovering or this is the possibility of your patient not recovering, and to put a hold to aggressive therapies. It becomes very difficult because we don't have solid evidence and solid numbers. So we have to work towards that. Having said that, we do now know from the Flurali, IM and HIGH trials that intubation is not really so bad in these patients. If you choose, because our understanding was immunocompromised patients, don't put them on intubate, don't intubate them, put them on NIV. But this trial has showed that actually if you intubate early, the outcomes are not that bad really. So it is about personalizing your care. And it is not about just because a patient is immunocompromised because of cancer or any other chemotherapy, it does not mean that that patient will not improve with early intubation. Similar is the case whether you have to put these patients on NIV or HFNC or intubation. Again, there is not clear data, but we have to take this. The one point that I would like all of you to take home from this is, don't stop yourself from intubating a patient if you feel that intubation is going to help, just because this patient is immunocompromised. Next, coming to bronchoscopy for diagnosis. We all know immunocompromised patients, bronchoscopy gives us scope to send sputum or whatever bowel cultures for rapid diagnostics or cultures, so that we can direct treatment. Again, this puts patients at risk of deterioration during the process. So, do we do it or no? So, the approach that has been described is, look at the pretest probability. What if you get a positive result from a test that you are doing? Is it going to change the outcome in this particular patient? Are you going to do anything differently? If you are going to do it differently, then you can go ahead and get bronchoscopy or any other invasive investigation that you want in this patient. If that is not the case, then it's better we refrain. The third interesting study that I came across is non-invasive diagnostics, like nasal swabs. In this study, it was done in 2019 though, critically ill hematological patients, immunosuppressed, when they did nasal swabs and they found positive for viral infections, say H1N1 or other viral infections, they did poorly. Actually, they fared very bad. So this is maybe one thing that we can use. It is non-invasive, it's only a nasal swab. Maybe that will help us make decisions going forward. Then another paper looked at disparities among patients with respiratory failure. I felt this is very, very relevant in our situation as well. And I was surprised to see that it is the same in an advanced, so-called advanced society like the United States of America. So basically, the prevalence, outcomes, all of these are much, much worse in lower socioeconomic, which is defined by insurance. Basically, in this study, the population that they looked at, it is defined by the amount of insurance that they have, whether it is private, whether it is government funded, and the outcomes, prevalence, ARDS, identification. You won't believe when lung protective ventilation was lesser in patients who had lower insurance. So they did not get lung protective ventilation. So they were not able to return to work, so that cycle of financial toxicity, they get into a vicious cycle. Also, racial, ethnical bias in pulse oximetry. Recent studies have shown that the recognition of hypoxia is later in patients with darker skin, so that automatically brings in bias. Then coming to the differences between males and females. Again, although the incidence of severe respiratory failure, ARDS, mechanical ventilation requirement is higher in adjusted when you adjust everything else between males and females, but frailty is higher in women and at admission to ICUs. But they have done large studies which have shown that if you are a female, then there is a greater chance that you will not be ventilated with lung protective ventilation, because we generally tend to not measure height and weight, and also institution of mechanical ventilation is grossly delayed when patients are female. Now, whether this is a social thing or whether it is an environmental thing or it is a biological thing remains to be understood. But we have to recognize this bias, because I am sure none of these patients who are in the biased group are part of any trial or any data that we have. So I think it's important that we should bring in this data. Then what do we do for survivors of sepsis? Several studies have looked at home healthcare options, where there is a nurse who goes home and takes care of these patients. Then there is a primary care guided, nurse navigator guided. None of these have evidence base, none of these are proven. ABCDF, Dr. Sindhu did a wonderful job in the previous lecture. She just said if you do ABCDF, outcomes are better. I'm just going to take you through 1 minute of what it takes to implement ABCDF. The same conversation that Sir was having with Venkatraman sir. This study, they looked at patients more than 18 years old, mechanically ventilated, non-mechanically ventilated patients. So they started this study 2011 to 12, baseline 11 ICUs in the US, they measured incidence of delirium, mechanical ventilation, duration, and length of stay. Between 12 to 13, they got a grant. They implemented a policy of delirium reduction in their ICU. It consisted of universal bundle policies. They incorporated bundle performance metrics into their electronic health records. They did education, bundle implementation calls, and training webinars were made over 1 year. Then after this, 2014 to 15, they measured bundle compliance over 1 year. Then in 2015, without any grant, they tried to extend this education and this program to 28 more ICUs. 3 years after that, 18 to 19, they measured data again. So this is just data about what they tried to measure. So after such a program, when they measured bundle performance, you can see pain assessment and management, there was no change. Daily SBT and SAT, there was no change. Re-intubation, no change. RAS assessment increased. Benzodiazepine infusions decreased. Non-benzodiazepine use, there was not much change. CAM ICU screening increased. Prevalence of delirium decreased. But routine mobility screening, there was no change. There was actually a decrease. And family engagement, although it increased initially, later on it dropped. Now, what is the outcome? The change that this made. The average ICU length of stay, they were able to reduce by half day, 0.5, and mechanical ventilation days by 0.6 days. And they were able to reduce the number of patients who stayed in the ICU for more than 7 days significantly. This is what they achieved. Now, if you look at sustainability, after 3 years, the SAT testing for spontaneous arousal trial, it came down to 45%. SBT, 53%. The preferential use of non-benzodiazepine remained high. And the others, daily assessment of patient mobility remained very, very low. Measures of family engagement also dropped significantly. So it takes a very, very Herculean effort to bring small changes in the ICU, especially in realms such as delirium. So my take-home message is improvement is a marathon, not a sprint. Special patient populations need special strategies. We need to unlearn and relearn, like for example, cancer patients. Post-critical care needs innovation and effort. We have to give dignity and quality of life, and also to keep ourselves sane, because you send a patient home and then that patient comes back after a month and dies, it doesn't make sense at all. Focused, sustained staff education is key. All students must teach, this is what I feel, and we need to develop better modules for skill development, technical and otherwise. Technology looks attractive, but it is expensive and not backed by evidence at present. Please go local with ideas and actions, but go global with data collection and publication. Thank you.
Congratulations, Dr. Varalakshmi. Very widely explained the base and means and different modalities to improve the patient outcome in the especially immunocompromised patients in the ICU. And now it's open for questions.
Yes, sir.
Starting ECPR is a big challenge. It took me 6 months to just educate our doctors, and a couple of them were already enthusiastic about doing it. But when it comes to actually taking the decision that I'm going to convert the CPR to a ECPR, I'm still finding it difficult for people to actually come up with that decision. Because not every CPR I am there, nor is the additional director level person there. Whoever is the person at the CPR usually calls up. And if you are calling up beyond 10 minutes, there is good data from UK that the outcomes are going to be poor. So you have to take that decision before the 10th minute. Then I'm going to convert the CPR to ECPR. So people will do CPR, ECPR, but what are going to be the outcomes is going to determine how we are going to look at that. And currently with my institute, we did 3, 2 we could not sustain. One survived and went home, but that's not the data that I can show off in an international publication and say that you've done excellent with ECPR. It's very difficult. ECPR as a concept is good. Implementing at the ground level, especially if you are working in a hospital where cost becomes the issue, it's going to be an extremely challenging thing. So, again, it is based on the institute that was there before, had given that decision to us. So, we had taken that. So, you need to sit with your cardiologist. Most cardiologists are not interested in it. Okay, that's the reality of it. Because it's too much of hard work, sitting at the bedside, doing things. They may be able to put ECMO for you if it is happening in the cath lab, when they have all those things at their disposal. Okay, but you ask them to take the patient to cath lab, they will say, can we do a bedside ECMO? You only go ahead and do it. So sit with your cardiologist, have a chat with them, tell them that if it comes to ECMO, allow us to do it. And nowadays what they are thinking is they are using the impella. So that's another problem. They are sort of, I would not say it's a problem if it's an appropriate indication that actually works well. Let me be very honest with you. But impella is going to be another stumbling block for cardiologists to adopt ECMO. So use it to our advantage, talk with them, say that if it's ECMO, we'll take over the case.
There is another word called impella. They use a combination of ECMO and impella. And for all of us who don't use impella, I happen to see a couple of impellas. It costs around 25 lakhs to close to 25 lakhs. So it's an expensive deal. So the other option which we were discussing is many of those patients who you give a SKY criteria. So we are nowadays using more of a SKY criteria for our patients who wanted ECMO or heavy ECMO. So in that we are talking about those last two, D and E. And we are now talking about a metabolic rearrangement. If my patient's cellular level oxygen delivery and perfusion is hampered and my lactates are going up, it's not just about the hemodynamics or macrodynamics, it is seriously my microdynamics are got affected. Probably those will not get affected better by any IABP or any noradrenaline. Those are the cases which we initiate.
100%. So D and E, D is essentially you have tried your therapy, but you have a metabolic derangement. That is what D is. And E is you left it too long, basically. So ECMO will help those who actually initiate it at the right time. Again, one more thing which I do before I start ECMO for every patient, I ask one question to myself, ECMO to what? So is this ECMO to recovery, or is this ECMO to transplant, or ECMO to nowhere? And if the answer is ECMO to nowhere, I don't put ECMO. It's very hard to say no, especially people who don't put ECMOs actually promise the families that we put the patient on ECMO and refer them to us. So now it's on your shoulder to say yes or no, especially the physicians, especially surgeons, cardiologists. How will put ECMO, he will stabilize. Yeah, they may stabilize for a few hours, but are they going to actually come out of it? So ECMO to what is the question which you have to answer. So if you work in a institute where me or Venkat Kola works, where transplant to everything is possible, then that question is easy to answer. But if you are in a center, though it's a tertiary care center, but no transplant facility is available, or it's only a few ECMOs that you do every year, then it becomes a very difficult question to answer.
Rahulji,
Yes.
you have mentioned about the cardiogenic shock ECMO role, but it's not related to cardiogenic shock ECMO role. But during COVID time, our friend we have cut him on ECMO and shifted for lung transplant. Can you explain the role of ECMO in lung failure, waiting for the transplant?
So excellent. If you have a patient who has got ARDS and because of which there is a complete failure of oxygenation, and in my thought process, if you've done everything possible, which includes appropriate ventilatory strategy and pruning, and you try to address the primary cause, and if the total ventilation days are less than 7 days, which includes non-invasive ventilation, please consider these patients for ECMO. And they will do exceptionally well if their care for and secondary infection doesn't take place. And if you have a transplant facility, obviously you exercise that option as well.
What is your experience in your center?
So we have very good outcomes with BV ECMO. In fact, we have one of the Hyderabad-based surgeons who comes and does transplant with us, lung transplant with us. Out of the 14 BV ECMOs we did, 8 were for patients who actually went and got a lung, and we could manage those patients for 20 days, 30 days waiting for a lung. So those outcomes are extremely good. Again, those ECMO patients who we retrieved from outside, who we actually went and put ECMO and brought them in, were probably poor decisions which we lost because they were already more than 10, 12 days, 14 days post their primary injury, as well as more than 7-8 days of mechanical ventilation. So when I'm talking mechanical ventilation, I'm talking about not only invasive, I'm talking about non-invasive ventilation as well. Because we talked about this patient-induced self-lung injury, the PCL. It is actually quite a bit of a problem if you ignore that in your ECMO decision. If you are going to put that patient on ECMO, then you might as well think of transplant in the same breath. Only then those patients will have a good outcome.
Thank you. Then what's the rationale for opting VV ECMO and VR ECMO?
Sorry, so what's the rationale for?
For opting the VV and VR ECMO.
VV and VA ECMO.
VA ECMO.
VA ECMO. So VV is predominantly if you only have a lung failure, oxygenation failure, which could, or a ventilation failure, which could mean both. Either oxygenation on carbon dioxide removal or both. Then it's VV ECMO. VV ECMO is the way to go. It's very easy. VA ECMO is almost like a bypass. You are doing a bypass, CP bypass in your ICU. Just that you are using a very modified pump as well as the oxygenator, which allows you to continue it for several days. Otherwise, VA ECMO has got a lot of challenges. VV ECMO does not have that many challenges. You can easily use it, as well as you don't really need to go up on flows very high at times. 50-60% of the cardiac output, if you can oxygenate through the VV ECMO, usually we are able to get through with reasonable amount of oxygenation index. Another thing which we are doing with VV ECMO is we are proning these patients as well. So if they are within the proning criteria and we put them on ECMO, we don't hesitate to prone them for 2-3 days on ECMO, and then we try to see if there is an improvement or not.
Thank you, sir.
Thank you, Varalakshmi.